talk about transperineal biopsy and the new technology that myself and Dr. Crawford are going to be releasing soon. So this is the music study that was recently published, 1,966 men with Gleason score 6 who had trust biopsy, and at the time of trust biopsy, if they were very low risk, 40% were upgraded to Gleason 7 or above, and if they were low risk, 59% were upgraded to Gleason 7 or above. And the answer to the question, if you have a repeat biopsy or negative MRI or a negative molecular classifier, the upgrading is 54% at radical prostatectomy, 54%. So when we talk about using these tests to select patients for active surveillance, we have to recognize that about 50% of the men are going to have not the appropriate disease. All right, this is another recent study of radical prostatectomy, 1,891 men. I just want to point out a couple things. One, we're still operating on too many men. 50% had Gleason group 1. They certainly did not probably benefit from a prostatectomy. And the other thing is, sort of the flip side, if the man had a Gleason 7 and you waited a year to do his prostatectomy, the biochemical recurrence rate was twice as high as if you'd done the prostatectomy earlier, which lends you to think that if I put that man on surveillance and I find out a year later he really is a Gleason 7, what are we doing to that patient? And this is Laurie Klotz's data doing active surveillance for over 20 years, and what they found out was that men who had intermediate risk disease had a 3-fold higher prostate cancer death rate than men who had Gleason 6 who were put on active surveillance. So again, that lends you to worry about if I'm choosing a man with a parent Gleason 6 and maybe he really has Gleason 7 or higher, am I compromising that man's potential survival? So we turn to MRI, and MRI certainly has been a huge advantage in helping us with the diagnosis, but we also have to recognize MRI has limitations. It does not detect 89% of cancers less than 0.5 cubic centimeters. It does not detect 73% of cancers less than 1 cubic centimeter. And if you're just talking about all cancers, but if you're even talking about just Gleason 7 to 9s, and those men with multifocal disease, which is the majority of men, it misses 29 to 50% of those cancers. So here's the answer to the prostate cancer death question. The 3 consecutive years since 2016, the cancer death rate has increased by 21% in those 3 years. So why aren't we talking about an epidemic? If any of the other cancers reported by the ACS had increased by 21% in 3 years, we'd be screaming. We're not screaming about prostate cancer. We should be. So a lot of us have turned to transperineal prostate mapping biopsy because we think it's a better way to identify cancers in the prostate, but there's no standardization of this technique. How many biopsies do you take? Do you take them every 5 or 10 millimeters? Do you take cores in line if the prostate's longer than 2 centimeters? And do you increase the number of biopsies if the prostate is larger? So when you read articles on transperineal mapping biopsies, they're all over the place on what the particular institution does. And so we defined, Dr. Gravitt and I, looking at the data at UC and the data institution in Greece, something called the biopsy density concept, where you take the ratio of the number of biopsies to the prostate volume. So for example, if you took 50 biopsies and a 50 cc gland, you'd have a biopsy density of 1. And so there's a number of papers, many papers published in the literature with the various techniques, and we have a study also in this list. And if you take that data and you do a line regression analysis, you find a really good correlation. The R-squared for this is 0.7 with a p-value less than 0. And you trace the line up and you see the cancer detection rate increases, and when you get to a biopsy density of greater than 1.5, that means if you had a 40 cc gland, you'd be taking 60 biopsies, your cancer detection rate increases by 50%. The red dots represent our study showing different cut points and how the cancer detection rate increases as the biopsy density rate increases. Okay, so let's talk about some changing technology we'll be introducing probably next year that may help us solve the problem of taking way too many biopsies. So in order to get to an answer about can we do a biopsy of the prostate and get actionable information would be putting that patient on active surveillance and not having to do another biopsy, not having to do another test, maybe goodbye for 5 years, like a colonoscopy, or can I get to a point where I have concise information to do focal ablation? So in order to answer that problem, you had to come up with 4 solutions, not one. And one solution is an adjustable needle that takes between 2 and 6 centimeter specimens, a needle that doesn't deflect, a gun or a biopsy device that allows you to shoot that needle between that length. You need some type of interactive software. And if you're taking a specimen as long as 6 centimeters, you need a place to put it. You can't drop it in formaldehyde and send it off to the lab and hope to get information about where that cancer is. So the idea behind the software comes from a paper written by Kepner in 2010, where they said if you drill holes in the prostate and you know the size of the hole and the distance between the biopsy sites, you can define the size of the lesion that you would not detect. So the math works out that if you took a 15-gauge needle and you did parallel biopsies from base to apex and you spaced the biopsies at 5 millimeters, you could detect a lesion as small as 0.04 cubic centimeters. So we wrote a program. This is a 3D look. Here is a 2D look showing the biopsy site right there. It's axial and it's sagittal. There's a pathology component that allows you to upload the results, and then you get a result that looks like this showing the cancer. And if you're interested in focal therapy, you get a 2D view that can be output in DICOM, and there's the cancer right there, so that can be married to any type of treatment planning platform, whether it be brachytherapy, cryotherapy, or some other therapy somebody else comes up with. This is what the gun looks like. There's the dial to adjust it. There's the length for 20 millimeters to 60 millimeters. This is Dr. Lucia taking a biopsy of a prostate. This distance measures 4.1 centimeters. There's the core, 4.1 centimeters. This is the pathology device. It's laid in here. That's a 4 centimeter core. Put in formalin, and then this could be processed intact. You label the base, you label the apex, and then you know where along this core the cancer exists. System launches sometime in 2020. We've got to do a lot of clinical testing where people are interested in doing the testing. I'd like to talk to them. The potential uses are to replace the current truss device we use in the office. We believe it'll be an improved tool for fusion biopsy, and then eventually we anticipate that we'll get enough information where we can do precision focal therapy for the individual discrete lesions that are detected. These are disclosures. Company members are myself, Dr. Crawford, Dr. Lucia, Mr. Busher, Wendy Pogue, and Dr. Craig Beer. Thank you.